This is my title, High-Risk Patients and High-Risk Plaques After ACS, and you'll note that I did not use the phrase vulnerable plaques, and we're going to talk about that in a little while. These are my declarations, and I can tell you I have no financial conflicts in relation to the material that I'm going to present, and all of the studies that are from our institution were funded by competitive grants. So Peter Libby has been elegantly talking about some of the change in pathophysiology, and this is the classical picture from Michael Davis at the time of the plaque ruptures, and that was the focus. But what we are talking about now, with this discussion about inflammation within the wall and apoptosis, both within the wall and in the endothelium, is some novel insights into understanding, some changes in the key mechanisms, and perhaps some unresolved questions. So some people have seen this image of plaque progression, and it looks nice. It looks like it's a good illustration of what happens to you and I after our lunch, or maybe after a longer time than that. The lipid-rich plaque, the erosion, and the rupture. So that's the classical presentation, but that classical presentation is almost certainly wrong. It's almost certainly wrong because, as you've heard from Peter Libby, it occurs only in a minority of the cases. Secondly, there is no adaptation in this wall. There's no positive remodeling. And thirdly, the progression is likely to be stochastic in steps rather than gradual, the way it's seen here. So I showed you now an example of one of our failures. This is a patient who presented to us with a plaque rupture and acute coronary syndrome. And at the time of the plaque rupture, he had this lesion, and his angiogram showed that he did not have a significantly stenotic lesion. Even if he used FFR today, it wouldn't have shown a significantly stenotic lesion. So he was started on what was then the current secondary prevention. Unfortunately, he didn't heed some of the lifestyle advice and continued smoking and various other things. His plaque grew. He had a second plaque rupture, and he died an arrhythmic sudden death before he could reach hospital. But this shows you that the changes may be abrupt rather than smooth transitions. And I want to show you this as well, because this is from one of our studies where we are looking at the endothelium of a human coronary artery. And the normal cells are the ones that I'm pointing out here. However, here is the erosion. Peter Libby's just been talking about the erosion, and here's an example of the erosion. These are mononuclear cells, and these are platelets. As Peter's pointed out, thrombosis is implicated after these erosions. So here's an example that an erosion may be implicated, and the hypothesis that we're putting forward is that understanding these mechanisms may help in future therapies. And it's a different plaque progression paradigm. And I'm suggesting to you that plaque rupture is neither rare nor singular, because many of these are erosions, and the balance between progression and repair may be modifiable. And you've heard some of the evidence where statin treatment may be modifying inflammation within plaque and within the wall. And going back to both studies from Michael Davis and from Renu Virmani and others, and Erling Falk, in looking at people who are the victims of a road traffic accident, not the driver, the victim of a road traffic accident without a chest wall injury, at the time of death, about 8% of them had asymptomatic plaque disruption, either erosion or rupture, and about 16% of diabetics and hypertensives, suggesting that this is a relatively frequent process. And this individual did not die from this erosion. Many of these will have healed. So most older individuals in developed economies have atheromatous plaques, but most plaques are actually benign and asymptomatic. So here's part of the paradox. From a post-mortem study, and this is from Vermani's group, the prevalence of advanced lesions was 100%. So every single heart they studied had at least one complex lesion. But in patients with MI, the prevalence of plaque rupture of the culprit lesion, just as Peter Libby has talked about, by OCT is less than half, or only about half. And the prevalence of thin cap fibroatheroma is just less than half. So what we're saying is that the paradigm of thin cap fibroatheroma being equivalent to vulnerable plaque is maybe outdated, because we need to look at more novel concepts about what's happening in the endothelium and in the vessel wall. And you know the data from, this is a Japanese study with angioscopy, and this Japanese study looked at an individual where there was an angiographic stenosis, and actually the angioscopy showed several lesions elsewhere where there would be evidence of thrombus that may be on top of erosions or may be on top of smaller plaques. We've demonstrated that from our large cohort from the GRACE program, that there is an important time course of events. And in the early days and hours, the individuals with ST elevation are the ones most at risk. But if you consider the individuals who survive the first 15 days, then it's those who presented with non-STEMI, for example, with ST depression, who have the worst long-term prognosis. And this entirely fits with what Peter Libby was saying about the change to non-STEMI and the risks of non-STEMI over time. And this shows you that the hazard ratio is significant despite adjustment for all the baseline risk. We've also looked, and this is a collaborative study that we did in the UK and in Belgium, at the long-term outcomes. So if you and I think that with current conventional therapy we've solved the problem, then we haven't. Because the 5-year death rates after STEMI and non-STEMI are approximately similar, even maybe slightly higher after non-STEMI. And these unstable anginas are not the UAs that you'll see today, because many of those would be reclassified as a non-STEMI. Furthermore, if we say to our patient who's been treated for non-STEMI, you're doing very well, off you go home, you'll be fine. Actually, we're not telling the patient the truth. Because the truth is, considering the entire risk of death over 5 years, for a non-STEMI patient, 86% of that risk is still ahead of them. So the idea that we have fixed the problem in the acute phase is perhaps naive. And what's more, in trials, we look at the time to first event. But for our patients, we're concerned about every event. So here we've studied not only the first event, but also recurrent events. And this shows you that the patients suffer, a number of them, more than one MI, more than one revascularization, more than one stroke, and importantly, half suffer further unstable angina admission. And that's the total number of events. And interestingly, we found exactly the same data from Belgium and from the UK. And you've also heard a little bit about the PROSPECT study from Greg Stone, when they looked with IVUS in relation to culprit lesion-related events and non-culprit lesion, and found contributions from both of those. Again, making the point that non-culprit lesions are contributing. So the so-called vulnerable plaque, how could we potentially target that? Well, we had a crazy idea that we could focus using monoclonal antibodies. And so what we did is, you cannot use commercial microspheres to do this, because commercial perfusion microspheres contain albumin, and they stick to endothelial surfaces. So we developed our own microbubbles with a phospholipid membrane that doesn't stick to everything, and then used a linking molecule on the surface, and then a modified antibody on the end. And we targeted, for example, CD54 or TNF-alpha in order to localize where the plaque erosion events occur, and demonstrated that that was possible. And then the next crazy question is, can we image in much more detail vessels using, here you can see the data with laser light. This is from an experimental study. And James Sharp in our institution published this in Science. And this is not OCT, optical coherence tomography. This is optical projection tomography. This technique was devised in our university, and the patent is owned by the university and the Medical Research Council. And basically, it allows the penetration of up to a cubic centimeter of tissue. And because this is laser light, it has exquisite resolution. So this is a cross-section of an internal mammary artery, but it's from an entire artery. And this transverse section, you can see all the layers from the endothelium through the media, through the adventitia. And it's possible then to put in probes and layer and identify which pathways are upregulated without dissecting the tissue. And this shows you one of the internal mammary arteries from an experimental sheep study, and you can see the superficial thrombus with our 3D reconstruction. And this is actually incidentally from one of the isolated hearts where we're looking at the inflammation process. And one of my colleagues is concerned with the changes in inflammation in vessel walls and in the kidney. So we went on to ask the question that we've got a problem because there are real challenges in polygenetic disorders. There are common cardiovascular disorders influenced by lots of genes. There's a lot of variation in phenotype, and there, importantly, are gene-environment interactions. Is there such a thing as vulnerable genes? Well, perhaps that's a very naive concept. So we asked an interesting question. We said, okay, there's going to be a host of susceptibility genes in all of us that are involved in atheroma development. And these are modulated by environmental factors and obviously by treatments as well in terms of their manifestations. But we are interested in this study in disease modification and whether or not certain genes are implicated in advanced lesions. And so what we did is we used our large program and have defined prospectively the genetic profile of individuals in this large program and followed the individuals in the studies in 3 different countries. And we did detailed phenotypic characterization, and we know that this is powerful in terms of the phenotypic characteristics predicting death, but it's much weaker at predicting MI. So we want the pathways that may be of interest in predicting MI. And it's informed by 4 independent genome-wide association studies. And these demonstrate that, for example, this is only one of the genes involved, but this is the 9p21 locus. It's a relatively frequent variant, and the population attributable risk is considerable compared to some other genes. But it is associated with the development of coronary artery disease, peripheral arterial disease, diabetes, and aortic aneurysms. And there's been a series of studies by a number of individuals in different centers demonstrating the concordance of these findings. So what we did is we took 3,200 individuals in 3 distinct and geographically separate populations, in Scotland, in Belgium, and in Poland, and 5,500 controls. And we did detailed phenotype and follow-up and careful quality control. And the hypothesis is that there may be some specific gene variants not only associated with ACS, but also with recurrent plaque rupture. And interestingly, we found that this same gene that is involved in atheroma is associated with recurrent plaque rupture. And here I'm showing you the heterozygote, where you can see that the age and gender adjusted hazard ratio is increased by about 50%, even in multivariate adjustment. And my very smart genetic colleague said, well, that's very interesting, but this can't be right, because 9q21 lives in a gene desert. On either side, flanking it, are very uninteresting blank molecules. This can't work. And we came up against a real stumbling block. And some very smart individuals from the University of San Diego did this study, and they demonstrated what's called remote amplification. This lives in a desert, but it's an enhancer that goes across the desert, and it enhances interferon gamma STAT1. A couple of the inflammation pathways that Peter Libby also talked about, quite interesting. Some evidence of gene-environment interaction and also remote amplification. So I'm not suggesting to you that this one gene is implicated. This is only an illustrator of the many genes that are involved. But it's a process that it's possible to elucidate through studies. And what approaches are we going to have to identify what are truly the vulnerable plaques, not just the structure that, as Peter Libby has said, the thin cap fiber atheroma is not the whole answer. So we've taken a number of approaches. And this is Michelle Williams, who's one of our PhD students, did this imaging. And you can see that there are some great lumps of calcium in the CT. This is a 320 slice CT in some of the coronary arteries. But actually, it's not the great lumps of calcium that we're worried about, because these are often well organized. And she went on further to look at, with different Hounsfield units, the components of some of these plaques, but it doesn't solve all the problems that we need. Then we went on to, we have an interest in aortic valve disease, and one of my colleagues called this the ring of fire. It's pretty emotive. It's the inflammation associated and surrounding aortic stenosis. And here is what our cardiac surgeons see in terms of the explanted valve, but this is fluorodeoxyglucose with positron tomography showing the increased inflammation around this aortic stenosis, ongoing inflammation. So we went on to ask the question, can we detect some of this ongoing inflammation in the aorta? And Nick Joshi and Ajay Shah from our institution have this coming out in JAMA very shortly. So it was possible to detect a number of different lesions using fluorodeoxyglucose. But there's a problem. There's a problem because in terms of myocardial imaging, glucose is taken up by the myocardium. So it masks the uptake into plaques. And if we see here, this is patients with myocardial infarction, and this is using positron tomography with 18-fluoro-FDG. And there you cannot identify the plaques because of overlap of uptake by the myocardium. And you can't suppress that sufficiently. So we asked a different question. Let's look at a different probe. And here's a probe that's used in bone imaging. This is 18F fluoride, and it's taken up in bone and is quite successful in terms of bone imaging. And lo and behold, it lights up in the aortic valve. It shows in these same regions where there has been inflammation and organization. And that's in cross-section. And what's more, we've been able to demonstrate that the severity of stenosis matches extremely well with the uptake of the sodium fluoride as a marker that this inflammation is ongoing in even more severe plaques. And here in this study, I want to show you some of the data in patients with aortic stenosis. Mark Dweck, who's now a lecturer with us, did this with us, and he won the Palmley Prize, and he also, for some of the work, won the ACC Young Investigator in 2012. And what you can see is these are normals. These are individuals with normal 18-fluoro sodium fluoride uptake, and these are the increased uptake. And in each case, in the coronary heart disease, the cerebrovascular disease, the CHD deaths, there is a gradation with increased uptake in these higher risk individuals. So, asking the question, and this was funded by the chief scientist in Scotland in work done by Nick Joshi, can we identify high risk plaques using this marker? And here's the technique. I show you the computed tomography in this plane, and here's the positron emission tomography, and we have very high resolution images for both of these, and this is the fused image. What you can see is that over the coronary artery that is affected by, in this index case, there is conjoint uptake. And unlike the fluorodeoxyglucose, which is on the right, this time 18-fluoro sodium fluoride is increased in the culprit plaques. And why we can distinguish it is because, unlike glucose, it's not non-selectively uptaken by the myocardium. And we've been able to show the uptake. These are in individuals after an ACS event. And this is examples of people who've had, for example, here 2 AMI patients, and after the AMI, we've been able to image them and show the hot zones for their uptake. And then going on to ask a different question. Okay, that's in the context of MI, but what about patients who are apparently stable? Here's a patient who has had bypass surgery. You can see from the wires. And we're looking at 2 zones. From the angiogram, we can't see any very obvious critical lesions. There's obviously disease. On the CT alone, there are some big lumps of calcium. But actually, the hot spot is here with the sodium fluoride 18F. And this, if we look first at the yellow zone, and this is the virtual histology IVUS, what you can see is most of it is green. The green is fibrofatty tissue. There's relatively little in terms of necrosis. Whereas in this zone that looked benign, actually there is the greatest preponderance of the necrotic material. And this is showing you a quiescent calcified plaque without a high level of necrotic material, and in contrast here is one with a lot of necrotic material. And this was published in The Lancet 2014. So we went on to look at the biology of these plaques, and this is coming out in Nature Communications, and here is the part of the proof of what's happened. It's all very well to image, but what exactly is happening in the plaque? So the study was to look at people who are undergoing elective carotid endarterectomy. And these individuals were imaged ahead of time and separated into positive or negative 18-fluoro plaques. And the negative plaques did indeed have plaques, but they had no evidence of any of the adverse histology. They did not have increased alkaline phosphatase or calcification, and they did not have apoptosis or cleaved caspases, whereas the activated plaques did. So in my final slide, we have a long way to go. But I think that, as you've heard this afternoon, there are several approaches to identifying pathways involved in both plaque rupture and progression, including the progression after erosion. Patient phenotypes are important, and they interact with the underlying genotype, but they're potentially modifiable. And there are new ways of identifying vulnerable plaques, and early plaque disruption and microcalcification may be important and may be a novel target in the future. Thank you very much.